Welcome to Conversations in Interventional Cardiology presented by SCAI. My name is David Rizik from Banner University Medical Center in Scottsdale, Arizona, and I will be your host today. We have an exciting evening and an exciting topic. We're going to be discussing the first-in-human TAVR with the Navitor self-expanding intra-annular valve in an LVAD-associated aortic regurgitation, the so-called disuse aortic insufficiency. And we have a really terrific panel discussing the case. Will be Puvi Seshiah from the Christ Hospital in Cincinnati, and we have two renowned experts, Sachin Goel from Houston Methodist, the Director of Structural Heart Interventions, and also from the Christ Hospital, Santiago Garcia. Really excited to hear this, Puvi. Why don't you take us through this?
Thank you for inviting me for this SCAI session describing two cases of LVAD-associated aortic regurgitation. We are in a spot in the U.S. right now. We don't have technology to help these patients. The dedicated AR devices at this time of the publication did not enroll patients with LVAD, so we needed some solution for our patients. So the LVAD aortic regurgitation is very common. In about 20 to 30% of patients, within about a year, they all get at least moderate, if not severe, aortic regurgitation, and as much as 50% by 3 years will have moderate to severe AR. And this, the etiology is multifold, but surgery in these patients is high risk, and it's typically some sort of surgical repair is done at the time of LVAD implant, but most patients don't get this unless they have moderate AR. So dedicated TAVR devices are not available for AR in the U.S. Both JenaValve and J-Valve are yet to be available, and they're only available through trials. I think JenaValve trial is closed. We are close to getting that approved, I suspect, through the FDA. J-Valve is set to begin the trials again. Off-label TAVR has been used. People have used Edwards S3 valve with tremendous oversizing. The Medtronic Evolute valve has been used, all with variable success. So off-label TAVR, in general, oversizing is recommended, more than 20%. And S3 valve has a high risk of embolization due to the lack of valve calcification with oversizing. Evolute platform uses aortic anchoring and oversizing to prevent ventricular migration, but still has a high risk of embolization. On the right is a case of ours where we had an embolized Evolute valve, which we were able to rescue with a second Evolute valve. The Abbott Navitor valve is different from Evolute in that it has a very large outflow diameter, much larger than the Evolute valve. And this we felt was important for anchoring in the aorta to prevent embolization. We present two cases that we performed at our center in the past year. So case one, it was an 82-year-old lady with severe LV dysfunction. She underwent HeartMate 2 LVAD in 2012, and this was 13 years out from her valve, from an LVAD, and so it's pretty impressive that she survived this far. She had severe AR for the past year, and she came into the hospital with class 4 heart failure. Imaging revealed severe AR, which was continuous, and this is the difference in AR and LVAD patients. It's a continuous AR, and sometimes may be challenging to quantify by our usual methods. So these patients have continuous AR, which is severe. Cardiac surgery was deemed high risk, and she screen failed for the dedicated AR TAVR valves due to the presence of LVAD. But the heart team discussion, TAVR was recommended, and we discussed off-label use of TAVR valve, and in her case, we chose the Abbott Navitor valve. Her annulus was 75 millimeters. Ascending aorta was 37 millimeters. We oversized by 20%. The typical Navitor oversizing for aortic stenosis, anywhere from 8 to 15% is what the company recommends. For our patients, we chose over 20% oversizing. And what was interesting with the Navitor valve compared to Evolute is the size of the outflow diameter. The Navitor is 46 millimeters, and we predicted that this would help anchor the valve in the aorta. So this patient has continuous severe AR, and it's quite visible in this echo. And we don't use M mode much anymore, but that was a beautiful picture of M mode. So, yeah. And CT annulus is 75 millimeters. There is no calcification in the aortic valve. The LV outflow tract perimeter was 76, very similar. This is unusual for LVAD patients. They typically have much larger LV outflow tract compared to the annulus. So there was a paper published in 2022. This is out of China. They were trying to see if commercial TAVR valves would work in severe AR and sort of what anatomical features would help predict that. So they chose 3 spots of anchoring: annulus, LV outflow tract, and the ascending aorta. And if you had anchoring predicted in 2 of the 3 spots, they felt that TAVR was feasible. The study just got completed this year. They just published this in Neurointervention, and I don't have the data, but in that 100 patient study, the success rate based on patients who met type 1, type 2, or type 3 anatomical classification, the success rate was 91% with commercial TAVR self-expanding platform. This was not a dedicated TAVR valve. This was a self-expanding platform they called a venous valve, similar design to Evolut and Navitor. So the anchoring either in the annulus, the LV outflow tract, or the ascending aorta, 2 of the 3. So in our case, our ascending aorta was 37 millimeters. Initially, we entertained Evolut. We felt that the outflow diameter of an Evolut valve is about 38 millimeters. We felt this may not be adequate for anchoring, so we went with the Navitor, which is about 46 millimeters in the outflow tract. And again, the oversizing at the annular level was about 22%. And so based on the Aurora trial study criteria, this will fit 2 of the 3 anchoring annulus, and in her case, both the LV outflow tract will also anchor. So she'll have anchoring the LV outflow tract, aortic annulus, and the ascending aorta. So here is severe AR, and all our patients were done under general anesthesia and intubation. We tried our second case with MAC, but there was too much respiratory motion that prevented us from being accurate, so we converted that to general anesthesia. So in general, to have a very predicted depth, I would recommend going general anesthesia on these patients. So we had excellent deployment, and we were about 3 millimeters depth, and the final image shows there's no AR left, and the echo next day, we did not have any significant aortic regurgitation. Pretty impressive reduction. And the valve stayed in place. We didn't have any issues with embolization. It deployed like a routine AS case. Here's case 2, 61-year-old man, severe ischemic LV dysfunction, heart rate 3 in 2021. He had severe AR for the past 6 months. He came in with class 4 heart failure multiple times. Initially, we tried to get him into the trial, but I think it was the J-valve LVAD option was not open yet. Imaging revealed severe AR, which was continuous throughout the cardiac cycle. Cardiac surgery, again, was deemed high risk. So we went ahead with off-label TAVR. His annulus was 82, and his ascending aorta was 37 millimeters. We chose the Abbott Navitor 35 millimeter valve, which gave us a 27% oversizing. And in this case, the outflow diameter of the Abbott Navitor valve was 46 millimeters, which would really help anchoring in the aorta. So again, this revealed pretty severe AR. And here is our CT analysis. And the annulus was about 82 millimeters. Again, no calcium on the valve leaflets. The LV outflow tract was a little larger at 87 millimeters. And so we chose the 35 Navitor, which would give us more than 20% oversizing. If I'm not mistaken, it was close to 29% oversizing. And again, here, his ascending aorta was 34 millimeters, and the Navitor outflow was 48 millimeters. So we felt very comfortable that this will anchor in the aorta as well as the LV outflow tract. So this was the 35 millimeter Navitor. Again, we had excellent deployment. Depth was about 6 millimeters, and we had no AR. But what was interesting, right after we deployed the valve, you can see stasis of flow in the aortic root, and this is important because we did have halt in this case. His INR was not therapeutic for a whole 2 weeks after the procedure. Even though he was on LVAD, his INR was run between 1.5 and 1.7. We had halt in this gentleman very early on. And I think this is important to note in patients with this kind of anatomy, especially in LVAD patients. The aortic root has no flow once you seal that aortic valve. So it's important to make sure they get therapeutic really quickly on their anticoagulation.
Can I ask a question, Puvi?
Yes.
So, with this is a concern that obviously the heart failure guys and the heart failure VAD surgeons have. Do you alter the speed of the LVAD after the TAVR in these cases so that the valve has to open some? I guess the concern is if the speed is too high, then the ventricle is not doing as much work, so the valve is not going to open much, and all the flow will be through the LVAD. On the other hand, if you decrease the speed, then the valve is going to hopefully open some and reduce the stasis. What are your thoughts?
So during the deployment, we reduced the speed actually to prevent it from being sucked into the LV. But right after, we didn't change the speed. We left him at 5,600. That's what he came in on. We left him on that. But that's something that we need to go back to the drawing board and decide, not just for these kind of cases, but even for dedicated TAVR devices, JenaValve and J come in the future. What is our anticoagulation strategy? What is our, do we let the LV eject more than we should, and by decreasing the LVAD speed? Those are questions that we don't have answers for, and hopefully the registries that are coming forth will help us. And so I do suspect we're going to see higher halt, just because of the stasis of flow, and it'll be important to. The first patient did not have trouble with that; she got therapeutic really quickly. This gentleman had trouble getting the INR therapeutic for almost a month after, and we had to bridge him low inox multiple times. I'm not sure what the issues with this warfarin was.
If I can interject with a few comments here, this is a fascinating discussion. I think certainly pharmacology plays a role here, and pump manipulation also can play a role, but ultimately I see this as a kind of a patient variable that really depends on how bad the LV function is. And for some patients, just may not be able to open the valve, and that's why they have an LVAD in the first place. I would say we have to think a little bit differently about halt and not only tolerate it, but I wouldn't say embrace it, but accept that this is going to be part of the deal. We have cases of valve thrombosis, and I'm not sure outside of the risk of a stroke if that is a bad thing necessarily, because what we're trying to do is essentially prevent the aortic flow to go back to the ventricle. So I think if you have no spontaneous opening of this aortic valve, eventually all of these valves will thrombose, and we've been pushing for that in the clinical trials, not to use conventional BARC3 criteria, because that could really hurt the technology, which I think it's just a different subset of patients here.
So Puvi, why don't you finish, because I got a couple of questions for you guys.
Sure.
This is really fascinating.
And so the next day, there no AR. So in conclusion, LVAD-associated AR is very common. Dedicated valves for AR is still not available widely in the United States. TAVR systems for aortic stenosis have been used with reasonable success off-label. Again, this had concern for aortic as well as ventricular embolization due to the lack of calcification and the LVAD suction effect. Self-expanding platforms are preferable due to anchoring in the aorta. And in our experience, we feel that this is a better option than balloon expanding. And I would recommend oversizing more than 20%. The added benefit of Abbott Navitor here would be the larger outflow diameter, which may provide anchoring in the ascending aorta, preventing the valve from migrating ventricular. And this was the first two cases that we used the Navitor and LVAD-associated AR.
Puvi, congratulations. This is really, really terrific stuff. Santi, I'm going to start with you because you're the principal investigator of one of the IDE trials in this space. It seems to me this needs to be studied in clinical trials with the dedicated devices as well. Can you update our viewers on clinical trials and what's going on in terms of testing the valves with the dedicated valves in this with these patients?
Sure, you're right, David. This definitely needs to be studied in a controlled environment so we can hopefully have an indication. This is an unmet clinical need, and as Puvi pointed out, this affects almost 1 in 3 patients with an LVAD. 2 technologies in the United States, both are available in the setting of research, and one is ahead of the other one in terms of the regulatory pathway. Let me start with JenaValve. They have completed the high-risk study, ALIGN-AR, and we're all expecting an FDA approval, probably Q1 of next year. They're moving forward with the pivotal trial now, comparing JenaValve versus surgery in patients who are low to intermediate risk. And there will be a dedicated single-arm study looking at patients with LVAD. And that's technology number 1. Technology number 2 is J-Valve. We are now conducting, as you know, the IDE for high-risk patients in the United States and Canada and Europe and Japan. And that study will also have a single arm dedicated to patients with LVAD. Some of the differences between the 2 technologies, as you know, with J-Valve we can treat perimeters up to 1 of 4. The upper limit for Jena is 90. So I think many of these patients who have dilated LVs and outflow tracts and annulus, I think, are going to benefit from having these technologies in the market.
So that's great. So Sachin, none of these are approved yet. There's no approved predicate in the space. So this is a ray of optimism, albeit with some caveats. And I say that against the background of the 2019 meta-analysis of about 640 patients across 12 trials, Gen 1 and Gen 2, transcatheter heart valves, device success, low 80s, second valve, almost 10%, all-cause mortality at 30 days, 11%, residual severe AI, 14 or 15%. I mean, it historically in the meta-analyses, and even another meta-analysis published in Circ Interventions earlier this year, said the same thing. Mortality was high, residual AI was high, valve embolization and migration. How important is this work until we have something approved? How important is this work for our patients with AI who can't get into a clinical trial?
I think that's a great question, David. This is critically important. In fact, we have another meta-analysis which was published by our group. In fact, one of our research fellows who's now a resident across the street at Baylor College of Medicine, we updated the meta-analysis earlier this year in JACC Intervention. We have about 2,000 patients in that meta-analysis. And similar to some of the data that you shared from previous meta-analyses, we looked at the dedicated devices versus commercial devices. And with the commercial devices, the 30-day mortality was 3 times higher. The device success was lower. The risk of significant AI was more than twice as high as dedicated valves. Valve embolization was 4 times higher, and 1-year mortality was almost 4 times higher compared to dedicated valve. So clearly there is a huge unmet need for a dedicated device. But until that device unmet need is met, and also for patients who may not have access to such therapies for the foreseeable future, I think this study by Puvi and Santiago is really important. This is a novel use of this device, the Navitor, and I think the leveraging of the large outflow diameter to anchor this valve is certainly very interesting and makes sense. So I think this is a very important. Of course, this is a case report or case series. But until we have results from the dedicated studies, which thankfully are on the horizon here now, this is going to be an important tool in the toolbox, if you will, for centers that do not have access, perhaps, or patients that may not qualify for other reasons.
Santiago, I'm assuming you would say mandatory transesophageal echocardiography in these patients, mandatory general anesthesia, et cetera, in order to best optimize the outcomes, depth of implant, et cetera. Would you agree with that?
100%. I think you have to prepare for war. I mean, you have to anticipate. What the meta-analysis that you and Sachin were discussing are all for native AR. So that would be one standard deviation outside the norm.
Right.
I would say this is probably two standard deviations outside the norm, because in addition to the native AR and lack of calcium, then you have the pump that is essentially trying to suck the device into the ventricle. So I think absolutely you need these cases need to be done under general anesthesia T guidance. And Puvi, maybe you want to comment your strategy for these cases, whether you had a second vendor in the room, and whether you were prepared
I did have Edwards in the room. As a bailout if I needed, but you're looking at all the bailouts that have been done where our second valve was deployed. They were all in the either valve, an Evolut platform, at least in our experience, or another Evolut and an Evolut. So I felt pretty confident that with the aortic oversizing, we shouldn't have much of an issue of embolization of this valve.
So go back to that slide where you showed the oversizing, the 2 of the 3. Can you go back to that?
Yes.
I think, David, what got your attention probably is that the Navitor chart actually predicted for the first case a 27 and we use a 29, and for the second case it predicted a 29 and we use a 35.
You're on to me, Santi. You usually are.
Yeah.
So maybe explain that, if you guys might explain that.
So this was the Aurora study. So they were trying to predict if they can, by CT, predict the success of commercial TAVR in aortic regurgitation. So they classified anatomy based on where the anchoring would happen, whether it would happen in the annulus, whether it would happen in the LV outflow tract, or is the anchoring going to happen in the aorta. And they surmised that if you can have anchoring in 2 spots, either the annulus or the LV outflow tract, or the annulus and the ascending aorta, or the annulus and the LV outflow tract, you had a good chance of success. And they did this, and they just finished publishing. I didn't include that slide. It just got published October of this year in Euro Intervention. They looked at 100 patients, and they only included patients who met type 1, type 2, or type 3 anatomical classification. If they met those 2 of the 3 requirements, the success rate on those patients was 91%. And they had very little issues with embolization. And then the next slide will, so using an issue in terms of oversizing, and so here I compared the Navitor sizing on the top and the Evolut sizing on the bottom. So if you used a perimeter of 70, I think she was 75, it would have predicted a 27 Navitor for a commercial aortic stenosis case, which on purpose chose 29. 27 would have given us about 10 to 14% oversizing. We went 29, and then in this case it was 22% oversizing. So we knew that at the annular level we had adequate oversizing. And then at the aortic level, the outflow diameter of the Navitor is about 46 millimeters, which is quite large compared to the Evolut. The 34 Evolut's outer diameter is about 38. So we felt certain that with 2 points of oversizing, this valve will not embolize.
Sachin, I liked Santi's point about we're just going to have to get used to the idea that if we decide to treat these patients, thrombosis is going to be something that we need to make our peace with in a certain number of these cases. Are there things we can do in your mind to mitigate that risk, or is just the usual standard therapies, usual standard treatments?
I think that's a great question, and I think in my mind still a bit of an unknown. I think anticoagulation is important. The question is what kind of anticoagulation. Most of the times these patients are on warfarin, so I think that needs to be managed, which anyways need to be managed for a patient in the LVAD. I think the LVAD speed to me is a fascinating aspect. So we've done, a couple of these cases, not with the Navitor, but we always have our heart failure guy or the heart failure LVAD surgeon to monitor and to change the speed. So in my mind, it's always interesting, depending on, as Santi pointed out, the ventricular function, whether we can have some valve opening. In my mind, if we can have some valve opening, that's better than having no valve opening, and maybe that will reduce this thrombosis. So I think we need to understand this, and we're really looking forward to the data that will be generated with the LVAD and the JVAD registries to understand how to best manage and optimize these patients.
Santi, you guys published a series of cases, compassionate use cases, and the last I heard, you had follow-up on 17 at 1 year. I think it was 27 patients. I'm going off the top of my head now. Sorry. You had follow-up on of the 27. I think you had 1 year follow-up on the 17 of the patients, and I believe the mortality was like low double digit. Any change in that data right now?
No, because it was a compassionate use
Right.
experience that involved us and some centers in Canada. We're not, following those patients beyond 1 year. But what I would say that our experience with dedicated devices so far has been spectacular. I think all
Yeah.
those considerations about a second vendor, the drama that comes with potential embolization, really go out of the window. It's a very predictable procedure, and it works really well in this subset of patients. So we'll definitely need. I love the idea of now sponsors and the FDA being open to the idea of investigating this subset of patients that in the past has been neglected.
Puvi, you are to be congratulated. This is a very important piece of work for those of us who are involved with these aortic insufficiency patients. I think this is another great step. Final word.
So there's a subset that we still don't have an answer for, and that's the patients with prolapsed aortic valve. Those are patients you cannot use a JenaValve, or at least there's cautions, depending on how much prolapse. You cannot use a J-valve, same issues. So I think the story is not done with commercial
Yeah.
Navitor valves, so Santi, you've done most J-valve of anybody in this group. So your thoughts on prolapsed leaflets AR, and then with that I'll
Yeah, I think that there are some common elements to all these technologies, which is you need to have casts that are somewhat intact. And so if you have a prolapse just of the tip of the leaflet, I think you may be okay. But if you have the entire leaflet that is prolapsing into the outflow tract, there is no way to anchor, whether it's a JenaValve locator or an anchor ring from J-valve, and that can be problematic. And so those patients are not good candidates for this technology. The other challenge of these patients, I think, is an accurate diagnosis. And I think, we have all kinds of imaging challenges for AR in general, and those challenges get compounded in patients with LVAD. So these are patients that keep coming to the hospital with heart failure exacerbations, so the quote-unquote moderate, I think, deserve additional investigation in my mind.
Well, I'd like to thank our three experts. This has been a fascinating discussion. On behalf of SCAI and this very interactive session, I'd like to thank the three of you for taking the time tonight. My name is David Rizik, and I look forward to more of these discussions in the future. Thank you.